with the electronic part of the medical records. We are going to be, information is going to be overlapping because whatever systems that we use for paper-based medical records, we are going to apply some of that. Not everything. Everything is new. There are certain things that are new because it's electronic. So electronic and paper, well, kind of not too related. But the information, the way that we collect the information from the patient, how we organize the system, all the sections on the medical record are going to be the same. So that's big. And the regulations are going to be changing certain things because now we are going to have um, HIPAA, not only with privacy and confidentiality, but we're going to have now security because now we're going to get login information. Every single employee in the hospital, in the clinic, receives a login information. So every single time that you need to enter into the system, you have to use your login and passcode. So that's basically. So there are certain changes. For now, let's talk about these health delivery fundamentals. It is very important. So some of these chapters have some pre-test questions. So because it's a pre-test, meaning before we cover the material, we're going to see the material, the answers for these questions later on. But it's just for you to kind of read it and to try to make sense whether, you kind of, understand or you not understand. It's not required to get the right or the wrong answer. If you get it wrong, it doesn't matter. That's what we're going to learn. If you get it right, that is fine. So it says right here, this is a pretest, true or false. A patient who has surgery and an ambulatory care facility is required to remain overnight. Now, you know the answer to this. Pay attention to this question because it's very important. Patient who has surgery at an ambulatory care facility. So that's the key. So when you read the questions, the most important thing is to understand what is being asked. If you don't understand the question, you're just going to be thinking that every single option is going to be the right answer. But it's not. So ambulatory care facility means you go in and out. Remember, I've been telling you that. Outpatient, ambulatory means you go, receive your services, you go home. So the answer is obvious. It is false. You do not require to remain or to stay in the facility because remember, outpatients clinics, they close at 5 or at 6 p.m. Nobody stays there. We don't have the equipment. We don't have the people trained to take care of patients after hours. That's not how it is. We don't have beds for you to stay. So that's not how it works. So remember, it's just understanding the question. If you don't, then you're going to have problems with that. So read the question carefully. I know we're going to become a little nervous when we're taking a test. That happens to everyone. But if you are running, you have to read the question over and over and over. I'm telling you, I've been taking tons of tests. I have tons of certificates, license, and I have to take tests for all of them. Some of the stuff I'm going like, oh, wait a minute, I never heard about this. Guess what? Process of elimination, understanding the question, because if I don't understand the question, all the answers are going to look like any one of those can be the answer. So remember, ambulatory patients do not remain there. They do not stay there. They go home after they've been seen. Now, think about this one. I think that I mentioned during my lectures. The emergency department is considered an outpatient service. I don't know what you think. The answer is no. Oh, I'm sorry. The answer is true. Emergencies are considered outpatient. Why? Because most of the patient that goes to the emergency, they do not stay there more than 24 hours. And if you happen to stay more than 24 hours, I'm talking about from the moment that you've been admitted, called by the doctor. It's not when you are in the waiting area. That has nothing to do. It's by the moment that the doctors start taking care of you. Do you spend more than 24 hours over there? Do you stay overnight over there? You might stay overnight, but once again, not because you're being taken care of. It's because you have to wait long hours to be seen. Emergencies in general are not considered inpatients. It's an outpatient. It is ambulatory. Because after we decide what is it that happens to you, then we're going to send you to the department that if you have to stay, we don't keep you there. We're just going to stabilize you. And then we send you to the department according to the condition that you may have. So emergencies are outpatient. They are not inpatient. Now, if for any reason they keep you after they admit you for more than 24 hours, that's a different issue. But most of the time, you're just passing through. This is like the middleman. You're gonna go there, we decide what you have, then we send you to the ICU. We send you to the NICU if you're a newborn, if you're a baby, whatever the case may be. So again, emergencies are outpatient. The average length of stay in a long-term care facility is greater than 30 days. That is correct. The average length of stay. Someone who has an acute condition stays for no longer than 30 days. An acute condition is when you have something suddenly that happens, we can keep you for 30 days. But if you have a chronic condition, we're not gonna let you go if you have in a serious condition. So you will stay for more than 30 days. Remember, this is like nursing home facilities. You have a condition that is chronic. It's not something that you're gonna go there and then you're gonna say, oh, I'm getting better now, so I'm going home. No. This person probably is gonna stay there until they die. That's basically what it is. So that's just understanding. But the point right here, I want you to remember ambulatory, outpatient. Remember, this is the doctor's office. This is your primary care physician. This is not it's not an inpatient visit. Remember, inpatient means you're being hospitalized. You're being assigned a room. You're being assigned a bed. You're going to stay there. They're going to treat you there. Your family is not going to be there. The medical providers are going to be there. And an outpatient, you can go with everyone over there. And then you go and you go home. One more. Oh, no, couple of more. If a patient is readmitted to a hospital, readmitted. So the patient was admitted once and then again, the patient is going to go back. It's not the same day. It's not the next day. Anytime after. 1 month later, 3 months later, 1 year later, the patient, it is admitted back into the hospital. Do we use the same medical records, the same medical chart to document the patient's information? The answer is no. We do not use the same medical record for people that has been admitted because this happens once in a while. It's not that you are admitted all the time. This is not like the doctor's office when you come to the office whenever you feel like it. Then we keep the same medical records. But if it is a hospital that you've been admitted for any condition, because the condition might be different, we are not controlling you all the time. After you stay in our hospital, you're going to go home, we're going to do something else, and then probably you've been admitted for something else. Or even though if it is for the same condition, we are going to start a new medical records. Think about that, because this is important. These might be questions for your exam. Same with medical records from the emergency. Medical records from the emergency, whenever you go over there, we take care of you. After that, and if you come back, you return, we're going to use a different medical record. We're going to start a new medical record. So that's how it works. Any questions about outpatients, readmitted patients, about medical records? Can we use the same medical records just like we do in the doctor's office? No. If you've been admitted to the hospital, we will not use. Just be careful. I'm not talking about you go to the hospital to see your primary care physician. That's a different issue. In hospitals, we have outpatient clinics for everything. Cardiologist, gastroenterology, you go there, visit the doctor, then you go home. Those are ambulatory. So don't get distracted by the name hospital. Because hospital means the whole building. But when we talk about inpatients, we're going to discuss that later on. We have a list of what is considered outpatient and a list of facility what's considered inpatient. So that's what you're going to be understanding. Remember, the questions are not difficult. The problem is that we do not understand them because we don't know how the system works. So before I took all these classes, of course, if somebody have asked me, okay, do we use the same medical record, the one that we use in the doctor's office? We use the same system when we go to the hospital, and then any time that I've been admitted, readmitted, because admitted is the first time. Readmitted is that I keep on coming back to stay in the hospital. That's basically what it is. In a doctor's office, in an outpatient clinic, it's called established patient. It's someone that comes at least once per year. In a hospital, we don't know. You might be admitted one more time, you might not. Probably you die during that stay, so we don't use the medical record anymore. But every single time that the patient comes in a hospital, when you are admitted, remember, you are assigned a bed, a room, you are hooked to all these machines and being treated by the nurses, the doctors over there, and you stay there. That is admission. Has to be more than 24 hours. Next, the size of an outpatient facility is determined by the number of patients it seats each day. Yes, the size of any facility has to do with the number, the volume of patients that they have, the number of providers that they have, the number of exam rooms that they have. So that is the size of an outpatient. Remember, I cannot have something really small and bring 100 patients. They're not going to fit. So we're going to have something accordingly. So that's how it works. So the size of any facility has to do with the volume of the patients. The more patients, you're not going to open a big store if you know that number one, it's going to be very expensive. Number two, you're just starting business. You're not going to go and rent a big space. You might, change your mind later on when things start getting better, but at the beginning, start small. So that's basically, so it depends of the volume of the patients. So here is the definition for the ambulatory care facilities. When we talk about facilities, and all the time I talk about it, I said facilities, I said institution, I said doctor's office, medical office, I mentioned hospitals, I mentioned emergency rooms. Well, but which ones are the ambulatory? So ambulatory, also called outpatient. When you get exams, that's exactly what they're gonna ask you. They're gonna use these two words interchangeably because they are synonymous. They are the same. They mean the same. Ambulatory, you go. Ambular means to walk. You walk in and out. Outpatient, well, you go there, but you don't stay. We kick you out. So that's how it's written. So whenever you see the word in your exams, outpatient, ambulatory, immediately you put in your mind, oh, this is the doctor's office most of the time. Think about that because it's the most common place. Your primary care physician, that's ambulatory. So what services you're going to be receiving over there? Well, the services that you receive can be a variety of services. Remember, all the specialties. You can go to your dentist, you can go to your gastroenterologist, your cardiologist, your neurologist, your psychiatrist, anyone. Your podiatrist, your general medical doctor, your GYN doctor, your obstetrician, any one of these medicals, they can open their own office. And they don't need to be inside a hospital, but they also are inside hospitals. So when you hear the word hospital, read the question because we are not talking about hospital. Oh, the patient is admitted. No, I work in a hospital and some of the places, most of the departments that we have over there are outpatients. Your primary care physician works there. So usually in an outpatient, see, the patient do not require an overnight stay. We say that already. So if the patient stay there, it's going to stay there for less than 24 hours. In a doctor's office, usually you don't spend that much time. You might spend 3 hours, 4 hours, 5, the maximum. Because if you go 6, 7, the office is already closed. Now, these ambulatory care facilities can be private or public. Oh, wait a minute. What do you mean private and public owned? Well, it might be the doctor that owns the office. I own the building, I pay rent on the building, I hire the medical assistant, the nurses, whoever works with me, I pay for it. It's my office. That's private. What is public? Well, it probably is the same, has medical doctors, have nurses, have medical assistant, but this is not owned by the person that is working there. None. This is funded by the government. So that's basically what it is. When something is, oh, I'm going to public building. Oh, to this public library. Oh, wait a minute. This public museum. Because there is a money that comes from the taxpayers. It's not the government, that's what they call, but this is us that we're paying taxes. Go to the public school, not the private one. See, that can actually be the best example that I can give you right now. You're going to private school or you're going to a public school. Oh, they're going to teach bless. No, that's not the point. It's not the point of the quality of the services because there are doctors, nurses, they are trained in the same field. So it shouldn't be the difference. It's just that one is owned and they're going to charge and they're going to put their own fees and that money is going to go to them and they're going to pay taxes. The public ones, they don't pay taxes because that goes from the taxes of, the taxpayers. So that's basically what it is. That's why you have to understand this, that when you go to a doctor's office, the first thing that you as a patient gonna be asked is, oh, what type of insurance do you have? Can I see your insurance? Do you have insurance? can I have your insurance card, please? Why? Because private doctors or private care facilities, we don't take all the insurances. Most of the time, we don't take the government insurances. Now, why? Because the government pay cheap to the medical providers. So that's basically what it is. See, if I have my own office, and this is my private office, I invest my money in my office, I pay everyone who works with me, I rent the office, I own the office, then I choose which insurance I want to receive. So don't assume that because you're a doctor, you can take any insurance. That's not how it works. Now, let's go to the public sector. Hospitals have mass. They are required to take any insurance, health insurance, because this is a public hospital. It is funded by the government. Therefore, they are required to take every single insurance. When we start talking about insurance, we're going to talk about all the difference between how do we get paid through the insurance, if it is a public or it is a private office, because that's important to know too. Any questions about outpatients, private or non-private? This is the same private and non-private, private and public, for-profit, non-for-profit organization is the same terms, means the same. So whenever you hear private, for-profit, that means the same. If I said public, if I said government, if I said non-for-profit, it's the same. So that's basically what it is. So understanding this, now you can kind of, start, understanding what's going on. When you go to the hospital, that it is, a public or just government funded versus a private office. Once again, think about public school, private school. That's exactly how it works for the medical system. If you have money and you're gonna pay more, you go to this college that is private. If you want to pay less, probably not pay anything at all, then you go to a public school. Any questions? So let's mention some of these ambulatory care facilities. Doctor's office. I mentioned this like 100 times. Clinics, medical clinics. I also mentioned this. So what's the difference between medical clinics, doctor's offices? Well, doctor's office usually is one doctor, and they are the owners, and they don't have many people in there working with them. Medical clinics, you have more than one doctor, more than one specialty. It's like a little larger doctor's office, so to speak. But whenever you hear about medical clinics, doctor's office is the same. It's just a matter of, how many people is working there. Public health departments, these are these standing alone free clinics. Oh, I don't want to go to the hospital. I don't want to go to my private doctor. They're going to charge me for the vaccines for my child. You take them to these public health departments. And then you're going to get the free exams, physical exams. You're going to get the free shots and so on and so forth. So that's basically what it is. So remember during the COVID, they opened all these new little stands for giving you the COVID shot. Well, those are considered those. But there are many others that, still are there. I know some of the places that are free when you need to get your physical exam for school, for work, you don't have money. They do it for you for free. You want the shots. Oh, they ask you for the vaccinations. You don't have the, the vaccinations card. They're not gonna give you the job. Well, you go to these places, and it's not gonna give you a card saying that you have something that they don't know. They're gonna give you the charts, and then they give you a report of the results. So now you're vaccinated. Walk-in clinics, now these are the same as a doctor's office, medical office, depends on the type of scheduling systems that they have. Remember, let's put it this way, 99% of doctor's office, medical clinics, urgent cares, they have walk-in schedules, appointments. Remember, you just pass by and you decide to enter this medical center, you just register there. Sometimes if they don't have anyone there, they probably see you the same day that you go there. Not that you have to make an appointment, come back in another day. So that is walk-ins. Urgent care centers, these urgent care centers have proliferated, meaning has been established, most of them lately. That was before the pandemic, that we have lots of these urgent care centers. I used to work in one of my friends' urgent care. He has like 4 of them. And we do 24 hours. This is like an emergency, but it's not an emergency, it's an urgent care center, because an emergency means your life is at stake. Something that is urgent needs attention, but still can wait. So an urgent care is something minor, it's not something serious, something that we can control over there. If you have something really serious, you have to go to an emergency. But these are considered, again, outpatient. Outpatient surgery center, see, the doctor is specialized in surgery. You're going to go there, they get your surgery. It's a minor surgery. You're going to go there and then you're going to go home after you finish the procedure. Diagnostic centers. Diagnostics are most of these imaging centers when you go for your CAT scans, MRI, X-rays, whatever. Because remember, some of the doctor's office do not have all this equipment within the office. So then we refer you to one of these ambulatory care facilities so you can get these labs done outside. The same with blood. So now you have an idea what we're talking about. So that's basically what it is. Here, well, we have these diagnostic centers. Not only are these imaging centers, but we can have also blood centers like Quest Diagnostics, like BioReference, like Northwell, and so many LabCorp. So these are, facilities, ambulatory facilities that we send you over there. You go get your blood work, whatever it is, and then you go home. So remember, if you go there and you do not stay there, you do not remain there, they do not assign you a bed, you are not diagnosed with the condition, then it is an ambulatory center. So that's basically what it is. Acute care facilities. Now, first, you have to understand what is the word acute means. Acute means a medical condition that it just happened, and it's not all more than 1 or 2 weeks. Because if it is more than 2 weeks, the condition, then you have a chronic condition. So acute is something that happens suddenly. For instance, you have a heart attack. You have an asthma attack. That is an acute condition. Now, if you have an acute condition, then you're going to be referred to a place when they can help you out, like an emergency room or emergency department, or to one of these urgent care facilities. You cannot go to your doctor's office for this because we do not have the equipment nor the people trained to help you out in that situation. So this is a short-term treatment for serious illness or injuries requiring stabilization, and active medical intervention. So that might be emergency or the urgent care. Remember, it's something that happens suddenly. It's not something that you have for a long time, because that will be chronic. You can have heart condition, you can have high level of cholesterol, you can have hypertension. But just because you have hypertension, just because you have diabetes, just because you have a heart condition, does not imply that you're going to be brought to an acute care facility. No, you're going to go see your regular doctor. But then you have a heart attack. Oh, that is something serious. It requires immediate intervention. That's what we do in emergency. Stabilize the patient. And when we stabilize, by stabilizing means, or by stabilization, we try to imply that the patient is not going to die immediately. So we stabilize. They are bleeding profusely, we stop the bleeding. The patient was having a heart attack, we put them back, not to normal, but the patient will not die of heart attack anymore. We already stabilized the patient. So now it has to go for observation. For other treatment, we're going to transfer our patient to cardiology or to whichever the department the patient is having the conditions about. So that's how actually works. And now I remember that I have to plug my computer. Okay. All right. So now it says right there, keep patients overnight or longer. Well, it depends of, what is the outcome of the patient. So that's basically what it is. Now it says right there, typically call a hospital. Well, yeah, most of the time, because you're going to end up in the emergency room because this is a serious condition. Or you're going to go to the ICU, remember. We're going to transfer you to the NICU. We're going to transfer you to any of these departments where they're going to do more. You are stabilized. Now we kind of save your life. Now they're going to do something else to keep you going. Because that is up to that was our job in emergency. So acute care facilities, we have examples of them. Remember here, we're going to talk about the non-for-profit organizations, for-profit organizations, see? So we have to understand when we read this. Why? Because it is important that we know that not that it is for non-for-profit, because whenever we hear for-profit organizations, not for-profit organizations or hospitals or institutions, with the first thing that we think, oh, this is a charity event. That's what they're talking about, non-for-profit. No. If it is funded by the government is the one that gives the money so this hospital can keep on running. They're going to pay everything. Everyone who works over there, that money comes from the taxpayers. That's basically what it is. For-profit hospitals, these are private. These are rich people that they get together and pay and build have the building and the installation, the equipment, they bring they hire all the personnel, all the practitioners. That's a different issue. So that's basically what it is. Now it can be in a non-for-profit hospital or in for-profit hospital. That's basically what it's trying to tell you. Because it is an acute condition. You can go either or. And within, you're going to find the emergency departments. We're going to find urgent care centers, long-term care facilities, rehab facility. So all these places, when you have something acute, say you have a terminal illness, so you're going to go to a long-term care facility, like a hospice. That's an acute condition. You We don't have treatment for you anymore. There is nothing for you we can do. So we just send you to a place when you're going to spend the rest of your days in a peaceful, calm, comfortable environment. That's it. We're just going to give you medications for pain. We're going to have someone who's going to clean you, who's going to feed you, and that's it until the time comes. Rehab. Remember, these are, drug abuse rehabilitation centers. We can have, after an accident, you broke a leg, so you're not going to be able to walk. We send you to rehab. So there, they're going to be training you. They're going to be, helping you how to walk again, how to move your legs, how to move your arms, your body all together. Because this is an acute condition. You cannot function normally until you go through all this. So that's basically what we need to understand. Now, are you going to be asked about all these things? No, just understand outpatient, inpatient, emergency. Because remember, every single time that a patient is being in the emergency, we are going to use a, what type of consent are we going to use when we are in emergency? Has to be implied. Remember, emergency, the patient's life is at stake. So for that reason, probably the patient is unconscious. We assume that that's the case if we're kind of literally talking about an emergency. So every patient, whenever you have questions about emergency and they ask you what type of consent you're going to get for someone who is in a critical situation, in an emergency situation, imply. We assume that the patient needs help. The patient cannot respond, so we just go ahead and help. We don't have to wait for the patient to say, yeah, I want to do it, or I don't want to do it, or what are the options. No, there is no options at this time. So that's why we need to understand all this. So whenever we encounter these questions, we know how to solve them. Hospital departments. So remember I mentioned it, if you go to a hospital, we're going to find all these specialties. That's what we call departments. In a hospital, you're going to find every single specialty. You're going to have pain management, GYN, obstetricians, surgical doctors, GYN doctors, urologists, cardiologists, gastroenterologists, orthopedics, anything that goes, for anything that the patient needs assistance. And that can be, most of them, outpatient. But we also have those departments within the hospital, like the emergency department. See, ED means emergency department. So what is the ER? Emergency room. Emergency department, emergency room is the same, all just emergency. Now we're going to have trauma centers. Remember, just because we have an emergency does not imply that every single hospital has a trauma center within the emergency. Now, sometimes there are 3 levels, level 1, level 2, level 3, trauma. Some of the hospital has level 4. So some of the hospitals only have 1 level or 2 levels, like the minor things. But if it is very serious, you're being shot, you're being rolled by a car, you're bleeding to death, we might not be able to attend you right here. So they bring you to a different trauma center. Intensive care units, those definitely every hospital has one, because that's where the chronic ill or acute patients are going to be brought to. We send every single patient that consider that it is at the risk after we stabilize them, we're going to send them to any of these departments. and they're going to stay there. They're going to be admitted. They're going to be treated until they get better or else. So that's basically what it is. So it's very important that we understand not just, oh, it's a hospital, so hospital, inpatient, inpatient. No, that's not how it works. We have inpatient and outpatient setting within a hospital. Offices, doctors' offices, clinics, all of them outpatient. So that's how it works. Okay, so let's talk about these ALOS, OLOS mostly we use. That's called average length of stay. Remember, we always kind of identify the conditions that the patient have by the time that they might be hospitalized. So if I said hospitalized immediately or admitted in the hospital, because those terms are also interchangeably and they are also synonyms. Admitted or the patient is hospitalized. That means the same. So again, very, very simple. It's not confusing. So we know that outpatient facility, they don't have any ALOS, any average length of stay, because the patient goes, do whatever they have to do, and they leave the same day. Faster. Sometimes you don't even spend 30 minutes over there. And then you don't, you go home. Inpatient, see, that's what it says right here. So these are the things that I definitely want you to keep in mind. Outpatient, inpatient. Where do you work, Mr. Alberto? Oh, I work in an inpatient facility. Well, that is false, because if just the fact that I work in a hospital does not imply that I work in an inpatient. No. Oh, I work in the ICU. Oh, wait a minute. That's for people who is admitted. That's called an inpatient. Somebody who's being hospitalized, who's being admitted. Remember, all these patients that have an acute condition, and an acute condition usually is something that happens in between 1 or 2 weeks. Then it says right there, the average length of stay is about 30 days, no more than 30 days. That means you can stay for 24 hours, for 30, 48, 72, 60, whatever time of hours, but it goes more than 24 hours, but less than 30 days. Now, the average length of stay for someone who is in a long-term care facility is greater than 30 days. So that's basically what it's trying to, what it's trying to convey right here. So again, understand outpatient, inpatient. Patient was admitted. Patient went to, this hospital and was admitted for this condition. This is an inpatient. You did this. Immediately before you have an answer, oh, this is an inpatient. Okay, what I would do with an inpatient that I don't do with the outpatient? What is it that the outpatient do? Then it doesn't happen in an inpatient facility. So that's how this actually works. It's a lot easier to see it that way. Says right here, how are going, not we, whoever, is thinking about opening an outpatient or an inpatient facility, says determining facility size, number of patients encountered per day. So see, this answer the pre-test question that we have at the beginning. So the number of patients, it is, well, what am I gonna have a big school if I don't have enough students? Having all the classrooms empty, having to pay for all these space without having anyone, or opening a big space when I still don't have enough clientele. So it makes no sense. So again, it's a lot easier to expand your business than to downsize. So it's better to go little by little. Inpatient facility, number of licensed beds, bed count. See, outpatients, we have to see actually how many patients are we, dealing with every single day. And of course, we need to know how many providers do we have. The more providers that we have, the more patients that we can see. But it's based on that, the size. Now, the inpatient, because you're going to have patients that are going to be admitted, are going to be hospitalized, they're going to be staying there for a period of 24 hours or more. So then we have to consider other things. Bed count. Where are we going to, place all these sick people? We're not going to take more people that we can hold. See, when I was in the emergency, that is something that I wanted to say before, but it kind of, slipped off my mind at that moment. But here I bring it up. When I was in the emergency, so there were patients that remains more than 24 hours in the emergency. I'm talking about the floor in the emergency, but it's not considered inpatient because it is called inpatient when we admit them when the room is available. Sometimes the rooms are not available, meaning the bed. There is no bed availability yet. Are we going to throw this patient out? No. We're going to keep it in emergency in one of the stretchers. And well, when the room is available, when there is a bed available, we're going to call someone and they're going to bring it to the floor. So that's basically how it is. Now, this inpatient facility has to have a licensed number of beds that you can have. It is not like you are going to open a hospital and you're going to put beds or bunks and one on top of the other because we're going to fill this with everyone. No, it doesn't work because this is for security purposes. How many people can be in one room has to be licensed. You can't just put 2, 3, 4, 5 people in one room without having the proper, authorization. So you have to have that. So it's a lot of things going on. See, it's not that simple. This is not like our home. I have one room and then I put a bunch of bunkers and fill it with people right there. No, it doesn't work that way. It has to be authorized, licensed on paper, like the schools. If you're going to have this medical assistant program, you have to be accredited to teach the program. If you're going to have phlebotomy, EKG, dental, anything, you have to be licensed to do that. So otherwise, it will be like just doing a course and giving your money away. So that's basically what it is. So most of these license, we don't deal with that. It's just that we work there. That's it. Everything else. But I want you to know how this operates, how hospitals, how outpatients work. Remember, sometimes you said, oh, I was admitted for this and they send me a bill for this much. Every person who is admitted, you're going to be charged. Like when you go to a hotel, you're going to be charged. Maybe your health insurance is going to pay. Maybe it's not going to cover everything. And the more time that you remain over there, and everything is going to be charged. If you're going to get meals over there, that is charged. You're going to pay for it. If you want a TV, phone service, you got to pay for all those services. Nothing is free. So for that reason, we need to know how many people we are going to be able to hold in this particular space. So nothing is free. Admissions and discharge. Now, think about this. I mentioned this before. I said you've been admitted. That's an admission. Admission is you were registered to the course and then you enter to take the classes. You've been admitted. Patients the same. And when you've been admitted, there are certain requirements that we ask a patient who is admitted, and there are certain requirements to allow patient that is not being admitted. Do they have discharge papers? Yes, but are totally different from the, inpatients. So no formal process for the outpatient. No, I'm just gonna follow up with the next appointment. Oh, don't forget to come back next time and do a fasting blood or go to this referral. But we don't give you a document that it says, okay, you've been discharged, because discharges have a post-admission guidelines, so you have to follow. So you follow a process. That's a different issue. If you have not been admitted, well, we don't have a discharge paper for you. We're just going to tell you, oh, well, we didn't find anything, so you're good to go. And if you have any issues, just call us, email us, come stop by the office. If it's something serious, go to the emergency, but we haven't treated you for anything. Even though if you're doing some medication therapy, things like that, I'm just going to refer you and just going to give you medications. But we are not keeping you in place. We are not running some tests when you are admitted. We're not paying these nurses, these doctors, these medical assistants to go there, draw blood, do EKGs, and do all these things for you. Place an IV, give medications, no. So you have to pay for all those services when you are admitted. And on outpatients, none of those happen. So there is no such a thing as, where's my discharge paper? When we go to an outpatient, we don't give a discharge paper. So basically, that's what it is. So for the inpatient, we're going to have a formal process for both admission and discharge. So we're going to follow these inpatient or hospital protocols. And what is the admission? Well, we're going to record all your personal information, right? Sure. Who is going to be responsible for paying your services? We're going to have the name of your primary doctor, because we're going to refer them, we're going to send them information about your stay, your admission, the conditions you have. We always are in contact with your primary care physician. We need to know that information. What condition were you admitted for? What was the situation when we admit you? So that's basically what it is. And then you come here complaining about this, the medical doctor is going to perform a physical exam. And we are talking about a complete physical exam right after you've been admitted. Why? Because we need to know what is your status, how you are doing at the moment of the admission, through the time that you're going to be in the office, and we're going to see the changes, whether you improve, whether you get worse, by the time of discharge. So, different protocols. Now, for us to admit you needs a doctor's order. The doctor decides whether you need to be admitted or not. This is not the decision of the nurse, not the decision of the medical assistant, nor the decision of the patient. I want to be admitted. I want to be admitted. No, there is no reason. So we're not going to admit you. You're going to follow with your primary care physician, because the doctor needs to document and show proofs what is the reason that this patient needs to be admitted. Because remember, if we admit you in the hospital and you don't meet the criteria for admission, the health insurance is not going to pay for the services. And we don't work for free. And that's not how it works. So it's got to be a reason why the patient needs to be admitted. And it's not a decision from the side of the patient or anyone else. It's the doctor. We're going to see a couple of more people who decides that. But once again, it's just talking about the medical provider at this time. We're going to talk about the day and the time that the patient was admitted, and the date and the time that the patient was discharged. Why? Because we are going to estimate or calculate the average length of time that you remain there, because we are going to charge you for the days that you were there and any other services that you require. This is like going on vacation and you just, rent a hotel room and all the services, you're going to be paying for it. Now, when I'm saying you're going to be paying for it, might be your health insurance, because I don't know how you're going to pay. But for billing purposes, we got to keep all of these. So again, each service is going to be different, depending of each submission is going to be different, depending of what was the condition, for how long you were admitted, on what exams you require while you were there. Everything, because we charge for everything. Every Band-Aid, every gauze, every needle, every syringe, every IV fluid, everything. The bed with you laying down, I'm gonna charge you for it. So it's not for free. Organizational chart. Remember, here we use the word chart. Why? Because it's the medical record, is the patient's information. So the patient files. So we can call it anyhow. It is used in business and medical organizations to illustrate managerial relationship. Now, once again, the medical records is when we document all the patient's medical condition, plus treatments, plus referrals, everything that we do, laboratories. So we need that. Here we go again. When we organize the information within the medical records, whether it's paper or it is electronic or digital, it's got to be in reverse chronological order. So the most recent should be placed on top. It is here again. Remember, this is a question for national certification. I have to repeat this like numerous times. I lost count. So it's very important. It is not just chronological order, it's reverse. So we follow the chronological 1, 2, 3, 4, 5, 6. But the last one is 6, not first. So the first one that we're going to encounter is not 1. It's going to be the last. That's what's called reverse. My patient I've been seeing my patient for the past 6 months. Every month my patient comes into the office. What should be on the top? The last visit. I'm not gonna go to the first one. I'm gonna go to, I open the file, last progress notes, I place, that is the last day that I saw my patient, not the first one. So that is chronological, but in reverse order. We file them chronologically, but when we are going to be taking care of the patient, we're going to see the last information that we collect from the patient, what we did last time. Based on that, we're going to continue. But if we need to go back to other, well, that's a different issue. Again, this is like your book chapters. You are reading chapters. The book has 10 chapters, and you already chapter 4. What is going to be next? 5. So whenever you stop right there, you're going to go back to chapter 5. You're not going to go to chapter 1 again or chapter 2. Oh, I read this already. You go back to whatever you left off. Okay, so inpatient care facilities generally have more complex organizational structures. Of course, how should not? Remember, in a facility where we have patients that are admitted, see, in the doctor's office, we don't have a section for the nurse. Why? Because usually if we have a nurse, they don't give medications over there because the patients are not admitted. We are not treating them over there. We have them for other reasons. But in a hospital, the nurses are a priority. They are like the middlemen for us. They have to be there, we give the orders for the medication. They have to be there giving the medications at that particular time, that particular route, that particular dose. And they have to go through every single patient that they have been assigned. So that's basically what it is. So they are continuously doing something. They are cleaning and, kind of wrapping up the wounds, doing a lot of stuff. They do a lot of stuff. Nurses do a very heavy work. Unbelievable. They do a lot. There is nothing compared with the nurses do. We don't do as much as they do. Unless you're a surgical doctor. Surgical doctors are all the time doing surgery. That's a different issue. But for us, we just asking questions, doing certain evaluation. Most of the things is ordering things, and somebody else does it for us. So because we have so much information about this medication was given, this medication, this procedure, say the patient is hospitalized, we have the patient hooked to all these equipments, blood pressure machines, pulse machines, we have oxygen levels being collected, an IV line is hooked to the patient. So we're checking a lot of stuff. And then, the patient needs an X-ray. Well, depends, we can bring an ambulatory X-ray machine to the room, or we transport the patient to the, to the radiology department to do CAT scan, MRI, whatever cannot be done within the patient's room, we're going to bring them somewhere else. So all that information is going to be attached because this is done daily. Every day, blood is collected, urine is collected, probably more than once, depends on the conditions of the patient. Medication has to be given more than once per day. So it's a lot of information. So we're going to have a lot of stuff there. Whereas in an outpatient facility, well, we don't have too much stuff. Because the patient comes in, okay, we order something, it comes there, but it's not something that is done during the time that they stay, they remain in the office. Anything else, is very simple. So we don't have too much stuff like that. So this is the flow chart of, any facility. So let's say this is a doctor's office. So what do we have here? Who is the CEO? Let's put it that way. Who is the head of the department? The medical doctor. What are the two branches, the next two branches on the chain of command? So this first is the doctor. He's the owner. He's the chief in charge. Then he controls everything, but do not delegate they delegates everything, but not everybody delegates. So is in charge of the financial part of his office or her office. And he's also in charge of other medical providers like nurse practitioners, physician's assistants. Remember, nurse practitioners, physician's assistant, they act just like medicals do. They can diagnose, they can prescribe, they can order anything that the doctor do. It's just that they get paid less because the time that they spend in school is less. A medical doctor spend 7 years at least. Nurse practitioner, 4, 5 years, depends on what type of nursing they have. Physician's assistant, 4 years. And it's a bachelor's degree. So that's basically what it is. Then you're gonna have an office manager. Well, that might be you. Office manager is someone who is a senior medical assistant or someone else that they got in charge, maybe a nurse that works in this part, who knows, whoever they decide to put. And then you're gonna have all of these departments under the office manager. So let's say that you have, the point here is, let's say that you have an issue. Following the chain of command, who will be the first person that you will talk to about the problem? Your office manager. If you don't have an office manager, then you have a supervisor. Usually it's a nurse. So you will go to that person. You should not break the chain of command. Oh, I'm going to go to the doctor directly. I'm not going to talk to office manager. I'm not going to talk to supervisor. I'm going to go, well, that's a violation of your code of ethics and the chain of command. So it's not good. So if you have a question for your exam, be careful what I'm telling you. You have a question for your exam and they said, okay, when the medical assistant has any issue, who's the person that the medical assistant should be discussing this with? I'm just making it up because it's more likely like that. So if you're going to follow the chain of command, because that's what they're telling you to do, you're going to go to your office manager. If you don't see office manager right there, where are you going to go? Who are you going to talk to? Well, then it's going to say supervisor. Do not select the doctor. Do not select the doctor because he or she is not the person that you need to talk first. It's going to be office manager. So usually the answer is your office manager. Because that's how it works in medical offices. They have an office manager. If you go to doctor's office, your doctor, your child's doctor, you hear about an office manager. This is like when you go to a department store, who do you find there? A manager. So that's how it works. So be careful with this because it sounds like, unimportant, but it is. Because you have to follow the chain of command whenever you're going to do something. Any questions about outpatient, inpatient, admissions, discharge? Because this is important. And also don't forget, you have to follow the chain of command. If you have to report like serious lab results, who you go to? You're not going to go to the office manager. You're not going to go to the supervisor. They are not. Who ordered this particular exam for your patient? The doctor. So let's say that they give you a question when they ask you, okay, you are working in this particular department and you receive a call or some labs through the mail when you open them up and says that the patients have critical values. Critical values means there is something really bad about the results. Who are you going to report this to? Now, just because I told you that you have to go to your office manager, but your office manager is not the one who ordered the blood test, the CAT scan, the MRI, or anything at all. These are blood results. These are critical blood results. Who are you going to tell them? Your doctor. Your doctor. You go directly to that person. Because remember, whenever you receive labs or anything else, where are you going to place these labs? On the incoming box, which is to be reviewed. So one thing leads to the other. So these are related. They are intertwined. So we should not forget and take things. Oh, Professor Heuser, well, if I have any issues, I just go to the office manager in the office. No, not for everything. This is for issues that goes with the patients, billing department, patients talking about insurance and things like that. You're not gonna go talk to the doctor about this. First of all, the doctors do not know anything about medical insurance if you work in a hospital. Don't talk about billing, insurance with the medical doctor when the doctor is not the owner of the office. Do not. And you do not bother them with this because that's why you have the office manager or the supervisor in your office or someone in charge from the billing department. So these are issues that you not bring them to your doctor's attention. It doesn't work that way. What you do is anything that is related with the doctor order, then yeah, patient is refusing to do a procedure. Oh, you go to your doctor. Because your doctor needs to know why is this patient not want to do that? Because I ordered this. So if the doctor ordered it, you go to the doctor. Remember, any concerns about the patient? Not that the patient is rude. If the patient is rude, you're not going to tell the doctor, oh, the patient is calling me names. That sounds, I mean, that's silly. And it's common sense. You're going to be addressing these questions with your doctor when there is a serious matter with results, labs, or anything else, or your pay. You want to raise? Well, you're not going to talk to anyone else, right? You can probably talk to the doctor. But we're not talking about that. We're talking about medical care. So that's basically what it is. So always follow the chain of command. Rehabilitation facilities. So usually because rehabilitation is like a very long word, right? So we use we kind of cut it down. So instead of, we abbreviate it. So we use rehab. Oh, patient is going to be sent to rehab. We recommend you to go to rehab. So that's basically what it is. So rehabilitation or rehab facilities are considered inpatient care. Remember, we send this person over there because he has a problem. They have to be treated by a specialist, so has to be admitted. And they're going to have a medical record over there, and they're going to start writing all the information about the patient while the patient is in that place. So that's basically what it is. So what is the purpose of, admitting these patients in rehab? Well, to fix the problem, well, at least try to fix what's the problem that they have. Remember, it works a lot for people who got into trauma. Physically, they are injured, they suffer trauma, they have a broken bone, broken hip, broken anything. Now we're going to help you to regain that trust, going back to walk. We're going to help you to learn how to walk again. So those are the things that we do. Yes, for drug abuse and alcohol abuse, well, it's a little different. It's difficult to get these people back on track, but these people are just going to do their best again. But mostly that's what we do. So it says right there, he specializes in physical medicine. So that is, the orthopedics doctor who works with muscles and bones, refer the patient after a surgical procedure or from a broken bone, something have happened to the patient. So after trauma, we send you over there. Or some other operations from the surgical department. Remember, one of your legs was removed, amputated, your arm. You have to learn how to use all these other mechanical devices. Of course, we're gonna send you to a occupational therapy. Remember, there are different types of therapy: physical medicine, physical therapy, occupational. Remember, occupational means we have to get you back on track so you can go and work and do the activities that you used to do prior to have this problem. How to handle, how to do your job. Remember, there are many conditions that kind of limit us to continue doing certain works that demand mostly physical, activity. So this just help you with that. Drug and alcohol abuse. Again, we hear about a lot about rehab. Oh, they go to rehab, they go to rehab, but there are different reasons to go to rehab. In general, the bottom line for this slide is that rehab facilities are inpatient facilities. That's it. Long-term care facilities. Now, remember, for these long care facilities, because these are long care, it goes beyond 30 days of stay. Back in the days, someone who has a chronic condition, they can stay in the hospital for years. Not anymore. Now, the hospital, you're not going to be kept for so long. After the acute condition is being stabilized and you're going to continue with the problem, we're going to send you to these long-term facilities. We're not going to keep you with the hospital. Used to, the hospital have the long-term care facility, like nursing home. It was right within the hospital. Not anymore. Now the nursing homes, these facilities, long-term care facilities, are outside the hospital. Most of them. They still have some of the places, but most of the time it is an independent facility building. So remember, that's what really is important to understand the average length of time that you remain in this particular place. Other places that we can consider a long-term care facility are skilled nursing facilities. So again, skilled nursing facilities is like, this long-term care facility, nursing homes. This is just a different name, but it's almost similar. Most of the time, well, they have doctors there. Versus nursing homes, doctors goes to visit them. So again, residential care facilities, rehabilitation hospitals. So we have a bunch of stuff where the patients are going to be there because the patient no longer can do things by themselves. They need someone one-on-one, probably. They need to be taken care of. And if you don't meet the criteria, then they're going to send you home. And they're going to assign someone who's going to be taking care of you at home. Home care facilities. So again, because of the insurance issues, they don't want to pay services in a hospital. They don't want to pay services in a long-term care. Well, they might, downsize or save some money by paying someone who's going to be helping you with your daily activities, but you're going to be at home if you have one. Home care, here it is. Remember, the services are offered directly in the patient's home. They have a home care person who is going to be assisting them. That's why we have these specialties that is called the home healthcare assistants, home aides. Remember, they only work in homes where patients need their assistance. And there is an agency who hires them, who trains them. There are many schools who trains these people. and they're going to be paid that way. And they're going to assign you a client, one of these patients, one of these homes. So that's basically how it works. So it's very important to understand that here, this is not a medical facility, this is your home, because you have one, and then we're going to send you over there. Because in a medical facility, you don't need someone because you are not in this particular state of disability that you can actually, do things from home. So that's basically what it is. So who works over there? Nurses. A nurse can be assigned, but most of the time the nurse might not be there all the time. It might be a nurse that, just visiting nurse. Physical therapists, occupational therapists. So these will be the providers that will be offering you some aid if you are from, you remain at home. So there's got to be a criteria for you not being admitted to one of these long-term facilities, or you choose that you want to rather be home, or your family decides that they want to have you at home. Again, there are different criteria right here to determine whether you can be at home or you can be admitted to one of these long-term facilities. So that's basically how it is. Outpatient chart. Now, when we have an outpatient, it says right there, single chart per patient. Well, whether you're an outpatient or an inpatient, you have to have a single chart. This is only your information, and all the labs and all the evaluations that we do is going to be in that particular medical records. And what is it that we are going to document? We're going to have all your information. We went through this already, so we're not going to go in detail. We're going to have all your personal information, family history, your personal medical history, family history, social history, your demographics, your name, your address, and all the contact numbers that you may have. Where do you work, insurance ID, and so on and so forth. Every single time that you come to the office, well, we're going to document all your visits. Any laboratory or imaging reports that we order and we receive, the results are going to be there. We're going to have probably information from other medical providers. Remember that if you are a general medical doctor, well, you're not a specialist. You might refer your patients to other doctors. So you're going to get results from other providers where you refer your patient. So that information comes back to us. And that doctor over there that did that particular procedure, that particular evaluation is going to get paid. And we're going to get paid too. So again, this is an outpatient. Used primarily by, physician, nurse, building staff. It says right here, used primarily by what is all this redundant information? So that means that these medical records can be used by anyone within the facility that needs to do work with the information. The physician, because the physician is going to collect the patient's information, of course, is going to order medications, it's going to order a procedure, it's going to determine a diagnosis, and it's going to have a plan, right? The nurse, because the nurse probably is going to use this medical record to give a medication to the patient or to do procedure. The billing department, because we need to claim services. We need to get reimbursed. So the information is there. So the billing department is going to use it too. That's why we were talking last time that when we have paper-based medical record and the billing department needed, the nurse needed, someone else is needed to do something, the medical assistant needed, but hey, we cannot use it until the doctor releases it. Because right now it's in the hands of the doctor. Until the doctor brings the medical record right here, there's no way nobody else can do it. Whereas if you use electronic medical records, everybody can be working at the same time with the medical records. So again, these are the advantage and disadvantage of all these. Well, we know already then the information that the medical doctor collects, or whether the physician's assistant or the nurse practitioner, because they are collecting the notes, the progress notes during that particular visit. Well, it's going to be a little more detailed, of course, because we are trying to determine what is the diagnosis of the patient. So we have to run lots of evaluations, order tests, whatever is needed. Depends of, the severity of the condition that the patient is having. Has smaller quantity. We're talking about quantity, not quality. Quality has to be the same, whether it is in an inpatient or outpatient. Is quantity, because we don't have that much information. Because we don't do medications, we don't keep you here every single day. So everything that we do today, tomorrow, is going to be added to the medical records. The other one, you come once in a while to our office. So we don't have too much stuff right there. Now, as opposed to the inpatient chart or inpatient's medical record, remember, for inpatients, a new chart needs to be generated, created every single time the patient is admitted. So don't forget that, because these are questions for exam. Remember, if you are in an outpatient, you carry on the same medical records from day one until the day that the patient decides not to show more in the hospital, the patient moves away, the patient dies. Then it's the time that we're not going to use the medical record anymore. We're not talking about the statute of limitation at this time, no. If you stop coming to our office, well, we're not recording anything else in your medical chart. That was the time that we end entering information on your medical records. So that's basic. In an inpatient, no, patient who is admitted, you were admitted today, we start a new medical records. When you are discharged, that's it. The medical record ends right there. You come back in another time, whether tomorrow, a day after, I discharge you already. So when you come back again, it doesn't matter how long from the day that you were discharged the last time, you are readmitted, we are going to start a new medical records. Regardless. It's not like, oh, go look for the medical record for this patient that was here. No. We no longer need it. Now, we are going to have some information recorded, particularly now that we have the electronic medical records, so we can see what was wrong with the patient last time that the patient was admitted. But again, we're not going to go back to the same medical records. We have to open another one. We might have the other one, but we don't use it. Remember, this is like a closed medical record in paper. After 3 years, the patient not showing up to the office, this medical record already becomes closed. We might have the medical records in our facility, But we're not going to start writing down next in a reverse chronological order. No, we're going to start a brand new medical record. The same one in electronic medical records. We might have the records from the patient there. We're going to use it as a reference. That's the only thing that we're going to do. But we're not going to start writing down on the same or adding another page to the old one. No, it doesn't work that way. The same with emergency. In an emergency, you come in, we create a new medical records. When you show up the next time, oh, let's look for the patient's medical record. It was here like a year ago, 6 months ago. No, no, no. As soon as the patient is discharged, nothing. Because patients who are in an emergency get a discharge paper because they were there supposedly with a critical condition. Now, I said supposedly because not every single one who goes to the emergency actually have an emergency. So in other words, 80% of the people who go to the emergency are actually not having an emergency. Maybe more. So again, all the information that is going to be in this medical record is going to be related to the reason or is going to be focused on the condition that the patient have during that admission, not something else. It's only that. So again, every single hospital that has, inpatient facilities, well, they're going to be using this type of, formats. Only because it has so much stuff going on during the admission. Imagine how many people is going to need that information to bill for this, to ask for this, to give referrals, to not only for billing, but all the personnel that is involved with this patient at that particular time need to have information about what's going on. Remember, it's got to be someone who's going to charge for the time that the patient remains there, the bed, if they have any services, extra services like TV, phone, internet, meals. Oh, they want this particular meal, not the regular meal. So everything, it is charged. So independent, parts of the hospital, like, the administrative personnel are going to be using all these things that are not related to the medical part. The food is not related. The stay is not related. The bed, whether you want an exclusive bed room, you don't want more patients there, you just want to be by yourself. Well, yeah, we're going to charge you for that. Oh, you want to have companions to be, to be allowed to stay. Well, you need a sofa, extra something. We're going to charge for that. Again, it's a good business, right? They charge for everything. But again, it's money. People who works there needs to get paid. The facility needs to pay bills independently, whether you receive funds from the government or not. But the government is giving you the money, but you have to make this money work. Other than that, they're going to remove the system that they're giving you. So we know what goes inside the medical chart. We repeated yesterday, we talked about a lot, but all the information that is collected from the patient, regardless, is going to be there. But here, once again, because we have the nurses, I mentioned that before, then in a doctor's office, they have a nurse, but this nurse is not giving medication, is not cleaning the wounds, is not doing different dressings. No, they are not doing any of those. We're not sending the patient to the x-rays, to the laboratory, back and forth. No, we are not drawing blood. 1, 2, 3 times per day, 4 times per day, giving medication 1, 2, 3 times per day. No. So it is different. So we have the nurse's notes. Here's when we're going to have the nurse's notes. We're going to have a page that's going to be like progress notes, nurse's notes. Progress notes are for the doctor, nurse's notes are for the nurses. Now, can progress notes be used for the nurses? Yeah, but then it's going to be in the section what is nurses notes. Because the template, if the template is blank and you have to fill in the information, fine. Now we have all these templates that the only thing you have to do is to check. If something is not there, then we add it. But with electronic medical records, it's a lot easier because the information can be copy and paste. So most of the information will be there. So that is the beauty. So here we have a bunch of medical specialties, particularly special because there is a specialist or specialty. We don't want to complicate that. It's just that we have all these departments in a hospital. We're not going to go through all of them. We're not even going to bother. I mentioned most of them. Remember, for those who took anatomy and physiology, relate the systems with the specialties. So if you have problems with your heart, anything about the circulatory system, well, you go to the cardiologist. Any problems with the nervous system, you go to the neurologist. If you have this chronic pain, nobody else can fix it, well, you might go to the neurologist, you might be to the pain management. If you have a child less than 18 years old, you go to the pediatrics department. And so on and so forth. So again, if you have female and you are complaining about, your hormones and all these, menstrual period thing, well, you're going to go to your GYN doctor. But if you're pregnant, then you're going to go to your obstetrician. So we have so many things. You go to the rheumatologist because you're having a problem with your joints. You go to your orthopedics if you have fractures of your bones. So we have all these departments. You go to the surgical doctor and different types of surgical doctors. For every specialty, we're going to have a surgical doctor. So again, this is just for you to know. You can review it. You can see, oh, this is internal medicine. This is family practice. This is an internist. This is a generalist. You're going to find all of these. Now, what is important to know this is because if you have to do a referral, you have to understand where are you referring the patient. Now, the beauty of all this is that the medical provider who is referring your patients is going to tell you, okay, do a referral for this patient to this place. That's basically you're going to go there and do. So whenever we refer someone, it's not the medical assistant will decide where the patient is going to go. The medical doctor tell us where should we refer, what's the specialty. And remember, the patients have a directory from the insurance company where they can select someone that, of their choice. Now, when they don't have someone in particular, because most of the patients, particularly the elderly patients, they said, oh, no, I don't know anyone. I don't know how to use this directory from the insurance company. Well, then we have a directory there from these doctors that, we usually, interact with them, and then I'm going to refer you to one of those doctors. But first, we give you the opportunity. Do you have a doctor that you want to go to? The doctor wants to see a cardiologist. Do you currently have a cardiologist? No, I don't. Okay. Do you have any cardiologists in your area where you would like to go? Give me the number, the name, contact them. I'm going to do a referral for you to go there. No, I don't. Then, okay. So we have some cardiologists numbers. contact numbers that we have here, and we can refer you to one of those if you, oh yeah, please help me out. So you always have to give the choices to your patients. Remember, no, that's not our decision all the time. It's not what we want. We try to help them all the time to make sure that, we count on them. This is the patient-centered care. Patient decides also whether they want to go. We have to count on our patients. We have to ask for their concerns, their opinions. So it's not just, oh, no, I'm not going to offer these people what they're going to do. I'm going to waste too much time. So I'm going to tell them, okay, I'm going to refer you to this person because I have it on file. No, give the choice, the chance, the patient options. Patient is going to like you, remember. It's like you go to a place and, oh, we only have this. Oh, but I see that, no. This is whatever is available. We don't have anything. Oh, we have something in storage. We don't want to show it to you because we are lazy to go there and get it for you. No. So if there is something that you might be interested, don't show me only when you have on display. If you have something in the back, in storage, that's what you're there for, to assist the customers, to assist the patients. So that's what we do, give them choices. So here are more specialties. Let's talk about these direct care providers. Now, it sounds like, what do you mean direct care providers? So these are the providers that are directly involved with your care. So your referring physician is not the direct care provider. This is the person that you always visit whenever something's going on, not whenever some occasional situations happens. See, the people in the emergency, these are not your direct care providers. They are during the time that you're there, but then you're not going to go to them every single time that you have an issue. You go to your primary care physician. That's what we call it, primary care physician. This is the person who takes care of all your needs. And because we do not know everything, then when something goes beyond our scope of duty, then we're going to refer you to a specialty or a specialist. So that's basically what we do. Now, this person, in order for them to be your direct care provider, of course, they have to be licensed in the practice of their choice. If you are a cardiologist, that's your practice. That's your specialty. So remember that I told you that just because of the fact that you're a doctor, does not imply that you can do everything doctors do, because we have different specialties for doctors. So that's basically what's important. See, the nurses, they are also specialized. There is a nurse for women's health, there is a nurse for pediatric department, there is a nurse for ICU, there's a nurse, emergency nurse. So they're special, family practice nurse. So yeah, you're a nurse, you know a lot of stuff, but sometimes you specialize, depends on what type of nursing license do you have. So everything that we do has to be based on, what the training that we have, what licenses, what do we have, what certificates do we have. And we got to abide by these organizations that provide those accreditation, those licensing. Those are called the licensing boards, because they require us to have certain, documentation to be able to get the license. First, you're going to go to this particular school that teaches that particular program. The school is licensed, is accredited to teach that program. Now you graduate from that school, you take the board, licensing board. Now you have to respond to them. How? We have to be renovate the license every single time. For you, medical assistants, you have to renew your certificate every 2 years if you take it with the agency that we use in the school. There are other agencies that you have to renew it every year. This is not a certificate or a license, if you're talking about a license, that we're just going to keep it forever and we're not going to do anything else. No. You have to get some, training after that. You have to be up to date in order for you to qualify. You have to earn some credits. You have to attend some symposiums on other professional, teaching programs that might be needed for you to keep up to date with technology. So all of that requires, not like, oh, I graduate from here, that's it, I'm done. Not so fast. You need a little more because every 2 years that you're going to be renewing your certificate, you're going to need to take some credits. There are not many, but if you don't do it, you're not going to be able to renew your certificate. So that's how it works. So if you are the person in charge of the treatment of this patient, you are the one who needs to document the information in the patient medical chart. So whenever I see a patient, it's not like just evaluating the patient and giving the patient a diagnosis, probably treatment. No, you have to document all this information, starting with how much time did you spend with a particular patient. Remember, we get paid per minute. That's how it is. So if a patient spends 10 minutes with me, the minimum time that I can bill for, the maximum time that I can bill for is 15 minutes. Even though if I spend 5 minutes, I get paid for 15 minutes. But if I spend 20, 25 minutes, now it's 30 minutes that I get paid. And so on and so forth. So the more time that I spend with my patient, the more money I'm going to be reimbursed for. Now, this money goes not to the doctor. This goes to the owner of the hospital, to the owner of the clinic. Unless you are the owner, then the money will come to you because that's your account. But when we work for hospitals, we are salary people. Remember, we work for them. So the hospital get paid, we don't care. In a hospital, I don't care if you have insurance, if you're gonna pay cash, you're not gonna pay cash, you don't have money. I don't mind anything. I just take care of my patient, do whatever is in my in my power to help them, and that's it. Because I know I'm going to receive a salary. So we're going to document all that because that's how the hospital, the clinic, is going to make money. Observations. Well, that's another thing. What is it that I observe? What I encounter? This is the objective part. Because that's what I'm evaluating my patient. Actions. What do you mean actions? Yeah, what actions I took after I found all these signs and symptoms, all this evaluation, all this blood, urine, body fluids tests, this imaging report, all the results, I have all that. What my action? I got a diagnosis. And if I have a diagnosis, what is my second action? Treatment. If there is any treatments to be given. Now we have to document everything has to be, the documentation has to be accurate, has to be complete. Sometimes we don't have problems with accuracy because it's very brief, the information. Patient have a headache, patient complains about having the headache for 3 days, 4 days, a month comes and goes. Well, not much information to miss. But the problem is sometimes we don't complete the encounter with the patient on time. And it's not going to be accurate if we do not complete this information that we collect from the patient during the patient visit or right after we dismiss the patient. Why? Because if I take care of another patient, I'm not going to remember what exactly the observations, the evaluations that I did on my prior patient, because now I have on top of my head the second one and the third one and the fourth one. So how accurate that's going to be. So that's basically what it is, because that's going to impact, that is going to affect the decisions that I'm going to make or the decision that someone's going to make for the well-being of our patients. So that's basically how it works. So everything sounds and looks pretty simple, right? So some people says, oh my God, being a doctor, oh, so cool. My God, they only think about, the title, about the money that doctors do, but there's a lot of responsibility out there. And there's a lot of things that we do. Just talking to the patient, but all that information needs to be documented. And from that information, we have to try to kind of figure it out what is going on with the patient. What is it that we're going to do to fix the problem that the patient has? Sometimes it's not just simple. It's not cut and dry. Not like that. Sometimes it's more than that. Requires lots of evaluations, testing, maybe getting other doctors involved, other specialties involved. So it takes time, and if we do not have this information accurate and complete, then can you imagine the decision that we're going to make for our patient is not going to be to the patient's favor. And of course, that's going to affect us too, because if we have a lawsuit, then it's going to come to us as well. Before we go on break, let's talk about these medical providers. Let's put it that way. So as I mentioned before, we have different types of healthcare professionals, different credentials, and each one specialized in something that they were trained for. And that's what they were licensed on, these particular specialties. Each one of them, the reason, what is the purpose of medical doctor? Well, to take care of the patient, to oversee everything goes with the patient's health. A medical doctor usually not only collects the information from the patient, do the evaluations, find a diagnosis, order tests, find a diagnosis, and gives treatment alone. It has to do a lot of things. But the most common things are the ones that I mentioned. We're going to order tests, we're going to do evaluations, we're going to give patient medications. Probably you're going to do some procedures if you are authorized to do that sometime. Remember, therapy means treatment. We're going to diagnose patients. And we're going to refer our patients to other medical providers, other medical healthcare professionals. Very simple, right? So you're gonna do everything that you were licensed to. Anything else is gonna go to someone else. Authorized medical orders and patients documentation. Remember, medical orders. I ordered my medical assistant to do phlebotomy, to collect urine, to collect any type of body fluid that it is within the scope of the medical assistant. Or to do this procedure, go to an electrocardiogram. We give orders to the nurses. Remember, the medical doctor is the one who gives order to everyone else. So we delegate most of the functions. So it's lots of responsibilities right there. On top of that, remember, we have to document everything that we do. If I give you an order, I have to document that order, and I'm going to be responsible for it. Everything that is written in that order is going to come to me. If I make a mistake, I'm the one who's going to pay the price because I gave you the wrong order. But you are going to pay the price too, because when you saw the order, you didn't verify everything that you're supposed to verify before you give the medication. Now, if the medication is something that the nurse is not familiar with, then it is your fault because you have to look for it. So again, it's not that you're going to argue every single time that the doctor gives anything, but you have to make sure that you evaluate as a nurse the medical record, not the medical assistant, because the medical assistant do not give medications. If you do not administer medications, it is irrelevant, this information. Samples of doctors, we have the dentists. So again, these are the doctors who treat, as the word implies, everything that has to do with the teeth, the gums. We have psychologists. Now, very careful with this medical professional, because a psychologist is not a medical doctor. Listen up, not a medical doctor. Medical doctors prescribe medications, diagnose patients, refers patients to another medical provider. Psychologists do not. They are doctors in the field of psychology that has to do everything with how the patient behaves. So that's basically what it is. But it's not, it is part of medicine, but it's not a medical doctor. Remember, a medical doctor must meet this criteria: prescribe medications, diagnose patients. If you do not prescribe medications, you're not a medical doctor. See, you're medical, you're going to be medical assistant. You're a medical provider. Medical provider is in general term of someone who assists the patient. You are working in a medical facility and you are helping, assisting the patients under, your doctor's supervision. But you cannot prescribe, you cannot diagnose. Nurses, they cannot prescribe. They need orders from the medical doctor. They just follow those orders. They do not prescribe. They do not refer the patients to another provider. They don't. So these are like any other profession. You see, oh, this is an attorney. Oh, he's a doctor. This is an accountant. Oh, he has a doctorate. Well, this is what happened with psychologists. They have a doctorate because of the time, the length of the studies, because it's more than 4 years. They have a bachelor's degree plus something else, but they are not medical doctors. Psychiatrists, on the other hand, they are doctors because they are doctors who treat problems of the mind, not behavior. Now, psychologists works with psychiatrists because whenever I have my patient, if I'm a psychologist, which I'm not, my son is, so we are kind of, working together. Most of the doctors, they work together. And with this particular case, we do it. Medical doctors are all the medical other specialties that I mentioned before. They are board licensed. Again, and it says right there, they have specialties and subspecialties. See, you can be a medical doctor, but then you specialize in this particular field. So that's how it works. You see, we have surgical doctors or surgeons, but they can do surgery in everything. You can be a cardiologist surgeon, you can be a orthopedic surgical doctor, internal organs, you work in this particular, you can be an endocrinologist, a surgical doctor. But just being an endocrinologist does not imply that you are a surgical doctor. No, you have to have this subspecialty. You graduate, you have the specialty, now you have subspecialty. Some of the medical doctors that are surgical doctors, they are not plastic surgeon doctors. That's a different thing. Just because I remove your heart, your kidneys, your lungs, I fix them up, I chop them up. No, doesn't imply that you can go do plastic surgery. That's not worth the way. Now you can become one of them, but then you have to go back to school, get the proper training. Now you have a subspecialty. That's how it works. You are a general doctor. You just do a little bit of everything, and anything else you have to refer them. But then, oh, you got a subspecialty or something else. Then you can practice that too. Say GYN doctors, for instance. GYN doctors, that's a specialty. Obstetrician, that is a specialty on or in it itself. So you can be a GYN and you can be an obstetrician. Remember, these are totally two different specialties. GYN deals with all the reproductive system issues of a female. That's what's called GYN. This is the doctor for women. Now, only is going to treat you for everything that you have, but at the moment that you become pregnant, this doctor don't deal with you anymore. I have to transfer you to an obstetrician. Now, because obstetrician makes a lot of money, then GYN doctors have the option, and they do most of the time, become obstetricians as well. So you are my patient. I'm being taking care of you as a female from day one, from the day that you were born. Now you're taking care of all your issues during adolescence, younger adulthood. Now you became pregnant. I'm taking care of you too. But if you're a GYN only, you cannot take care of this patient. Even though if it is your patient, you cannot take care of the patient when the patient is pregnant because you have to have a license for that. And that's a subspecialty. Any questions about this? Okay, so let's take a break. And when we come back, oh, we're almost done with this chapter. Oh, that's good. So we're doing great. All right, so when we come back, we're going to continue. So it is 7:07, 30 minutes break. Let's come back at 7:40. Okay? Fair enough. 7:40 it is. So see you then at 7:40. Get some rest.
Thank you.
You're welcome, guys.
Thank
Take care.
you.
Bye now.
Él dice mi mamá que ha venido a buscar. Por eso vino. Espero nunca buscar. No, para allá.
Okay, so we are back. I hope you guys enjoy your break. Let's continue with this healthcare delivery system. So we were talking about this type of doctor's specialties. So just keep it in mind for your own knowledge. Not that you're gonna be asked about this particular thing, but if you have a question when they ask you, okay, so you are taking care of a patient, the patient has heart condition, where should you refer this patient? So then you know that he goes to a cardiologist. So simple stuff, but sometimes if we are not sure about what we're gonna do. Remember, it's not that you as the medical assistant are going to refer. That's not what they asking you in the questions. They are putting you in a situation where, to do the referral, you're not gonna order a referral. You're gonna be asked to do referral. Where is the patient gonna go? To the cardiologist. So you're gonna do a referral to go where? Okay, where you're gonna refer the patient. It's not that actually you are doing the job of the doctor, so you have to try to understand the questions. Remember, this is like when you have a question for emergency. Okay, you are working in an emergency department, you find a patient who is unconscious. What type of consent you're gonna get from this patient? Implied consent. The fact that you are in emergency, it is implied. Remember, they're not telling you this person is talking, this person doesn't have an emergency. No, it's an emergency. So do not kind of put your ideas for the experiences that you have, because that's what drove us apart from the right answer, from reality. So that's how it works. Sometimes it's very simple. Sometimes it doesn't sound like they asking us, oh, Professor Hoyer said we're not supposed to be diagnosing. We're not supposed to be giving advice to the patient. Well, sometimes it's not what they are referring to. They're talking about you calling the pharmacy for the medication, not that you are prescribing. No, there are some medication schedules or levels that you can call the office. You are authorized by your doctor. So no, there's no way you're going to do it. So they are not asking you. The question is not about whether you are prescribing or not, whether you're giving a medication or not. So you have to try to understand the question, because there is no other options there. So reading the question, understanding the question is very, very important. So we talk about the nurses, whoever works in the medical facility, the doctors. Let's talk about the nurses now. So remember, in a hospital, particularly in a hospital or in a pediatric or pediatrician's office, we're going to find nurses that are specialized in pediatrics. They're specialized in most of the specialties. The same way that the doctor specializes in certain things, we're going to have a nurse, not surgical doctor, no, but it's a nurse that is trained in the OR, in the surgical department. So again, we're going to mention these different degrees, levels of nursing. Now, nurses, they have a license. They do not earn a certificate. They have a license. So that means that these nurses, just like doctors, they can only work and stay where they took the exam, the board. Now, we talk about reciprocity. We talk about endorsement. So when when a doctor license is accepted in another state because they have an agreement with this particular state, so you don't have to take any exams or anything like that, then it's called reciprocity. So if you've been allowed to work in another state when you are not licensed without having to go through all this trouble of paying again, registering, taking a test, then that is called reciprocity. If they take your license, your exams, your board exams, percentage, whatever grade you got, that is called endorsement. But they don't ask about endorsement. They like to ask about reciprocity. So just know that if my license is accepted in another state without doing anything else, don't take an exam, that's called reciprocity. So again, that is simple. Well, for nurses, they have different levels, the same as medical doctors have different specialties, but the nurses have different levels of training. This is based on time and duties that they're going to do. So LPN, you probably heard about LPNs. These are called a licensed practical nurse. So again, what is the difference between LPN, RN, an RN that has an AMD or BSN or CRN? What is all this? Or what is a nurse practitioner, nurse midwife? Well, different training, different length of time in school, so lots of things. LPNs are spend at least 12 months to 16 months in school. Every single LPN is going to earn a license. Remember, it's a license. But you're not an RN. You are below an RN. So that's basically what it is. They give medications, yes. But they work in level where, it's not too risky. So most of the time they hire them in nursing homes. So that's basically what it is. So they, let's say, title wise, they will never be a nurse supervisor. Usually they are not, unless you're in a nursing home, but not in a hospital. They are the lower level of the nurses. So that's basically what it is. RN. We have two types of RN. Well, more than that, but time-wise. An associated degree in nursing is called RN AND, and a bachelor's of science nurse, that's the BSN nurse. An associate degree is someone who do less than 2 years, up to 2 years of schooling. So you go to the school and you want to become a nurse and you want to have an associate degree, then you study a program that is 2 years program. Now, again, because it's less time that the bachelor's, because bachelor's is 4 years. So you're going to get more training. The length of time is longer. Therefore, money-wise, you're going to get paid more. So that's basically what it is. Most of the time, these nurses that are the nurse in charge, the nurse supervisor, most of the time they are BSN. They are the one who control every single other nurse. So that is based on, the time of the study. Those titles are the time that they spend in school. See, LPN, less than 2 years. RN, 2 years. Bachelor's degree, 4 years. Now we have the CRNA. Now be careful, this is not CNA. CNA is totally different. CNA is like home attendant. It's just the CNA works in a nursing home versus home attendant, you go to the home of the patients. But it's almost the same thing. It's just that you have to do different programs. But that's not what we're talking about here. This is a certified registered nurse who is also having subspecialty as anesthetics. It is an anesthesiologist nurse. So that's basically what it is. So it's very important for us to understand most of the titles. Sometimes we are in the workplace and this is a nurse, this is a nurse, this is a nurse, but it's a all-around nurse. But why is all of them nurses? Just like doctors, each one have a different specialty. And if you have different specialty, you have a different length of time that you go to school and training. Nurse midwife, now these are the ones who, assess the patients during childbirth. So those are the ones. That's the middle level. That's what's called midwives, because it's like a little level. It's not an obstetrician. Nurse practitioners, well, nurse practitioners are the highest rank of a nurse. So they go for a program, let's say the bachelor's, and then they do 2 more years as a subspecialty. And they get this subspecialty like the CRNA, which is anesthesiologists. They are regular nurses, but they were to learn how to administer anesthesia during a surgical procedure. And that's all they do. They don't have to do anything else. They just give anesthesia, stay with the patient for the time of the surgical procedure. But if something happened to the patient due to the anesthesia, you're responsible. So it makes a lot of money. Yes, they do. So again, but it has lots of responsibility. Nurse practitioner is a little lower level than medical doctor. Nurse practitioners do the nursing program. They do 2 years more. But before they become nurse practitioners, they have to work at least for 2 years in a medical facility as a nurse. And then you apply for the nurse practitioner program, for the NP program. Then you're going to specialize. Nurse practitioners, they specialize. Remember, it's not like you're going to be just a nurse. No, you have to select what is it that you're going to be specializing in doing. I want to be a nurse, pediatrician nurse. Okay, that's what you're going to learn. So you're going to be an OR nurse. That's what you're going to do. You're going to be an emergency department nurse. That's what you're going to be. You're going to be a family practice nurse. That's what you're going to specialize. So, and what happens if you get a job in something else? Well, unfortunately, you're not going to get the job. Just because you're a nurse does not imply that you can apply for any jobs because you already have a specialty. If you're a pediatric nurse, you work only in pediatrics because that's what your license says. Remember, this is like cardiology, only works in cardiology. Cannot say, oh, well, you know what, I changed in gears. I'm going to move to do now surgical because, oh, I'm sick and tired of this. No, you want to do surgery, then you go back to school again. So nurse practitioners have an advantage because they are just like doctors, but a little lower training. They can operate their own practices. They can have their own practices. They sign the medical records. They can see patients at any level. Again, when it comes to nurse practitioner, now things change because you're gonna specialize in something. Remember, every single nurse has to specialize in a field. Now you might say, yeah, everything that you have saying is the same, that, medical doctors specialize in this, nurses specialize in this. Yeah, everybody can specialize in anything. But when you become a nurse, that title goes with you wherever you go. If you want to be, you're a nurse practitioner, if you are a nurse that works in pediatrics, a pediatrician nurse, and you want to work in family practice, you're not gonna get a job like that. because you already have a specialty, and that's what your title it says. So you have to be very careful when you choose what you want to study, because you're going to get stuck with that. And if you didn't like that, then you have to go and do more study to change that. That's a super specialty. Now, physician's assistant. Now, physician's assistant is like nurse practitioners. It's kind of with the difference. Physician's assistants can work. What the difference are? Let's put it that way. A nurse practitioner can open their own practice. They don't need the doctor to sign for them. Physician's assistants need to sign, need a physician. So physician's assistant works under the supervision of a physician. It's not done, you gotta be on top of them all the time. No, the physician's assistants see the patient. At the end, they complete the medical records, but they don't sign it. These medical records goes to the medical doctor, whoever is your supervisor, and they're gonna be assigning you someone in your workplace. And then this person is gonna determine, is gonna sign, is gonna read everything that you documented. If they are agree with the things that are there, they're gonna sign it. If they are not, they're gonna ask you to do the pertaining corrections. So that's basically what it is. Nurse practitioners, they can sign their medical records. They don't have to wait for a medical doctor to sign their documents. Physician's assistant must do it. Now they don't call physician's assistants anymore. They call physician's associates. See, physician's assistants, medical doctors, nurse practitioners, they conduct physical exams, they do diagnose, they treat any medical conditions, they order and interpret the test result, they prescribe medications, they counsel patients, they assist with surgery, everything. It's just that they are a little below the medical doctor because of the length of studies and training. Physician's assistant takes 4 years. Nurse practitioners takes 5 years or 6, depends on what nursing degree they have. So that's how it works, but they almost do the same stuff. And of course, they get paid different. Now let's talk about these other professions, allied healthcare professionals. So these will be those professionals that are going to be, the liaison between the medical doctor and the patients. And that's what medical assistants are. So that's basically what it is. So you're going to be under the supervision of a medical doctor or a nurse practitioner or PA. See, anyone under doctor, nurse practitioner, and PA, they work under them. If you have a title that you are a technician or you're a nurse, not a nurse practitioner, you work under the supervision of these 3 most highest levels in medicine. That will be the physical therapists or PTs, occupational therapists, OTs, or respiratory therapists, RTs. So you probably heard about some of these. So they are in a lower level of, there's like in the same level of nurses. Clinical laboratory technicians, that might be the ones how, medical technicians, the one that processes all these blood in a laboratory. Diagnostic technologies. Now, they are not the one who are giving diagnosis. They are technologies, but they work in a department when you run all these testing. All these do like the X-ray technician, sonogram technician, MRI technician. That's how it is. Pharmacists. Remember, pharmacists are not considered doctors. Now, in this case, a pharmacy, these are technologies. These are technologies, pharmacies. Registered dietitians, audiologists. Remember, sometimes medical assistant, if it gets trained in the urology department, not urology or audiology department, which is medical doctor that deals with hearing problems with the patient's hearing situation. Clinical medical assistant, see, this is where you come to play. And it says clinical, why? Because the administrative one has nothing to do sometimes directly with the patient. You are more involved with the patient because you're assisting the medical doctor in procedures. You are actually doing some procedures like collecting blood, collecting stools, collecting urine, and assisting with the doctor some procedures. So that will be how it works. Now, this will be the clinical professional organizations. Those are the organizations that license medical professionals. So that's basically what it is. We have here the American Medical Association, the American Nurses Association, the American Hospitals Association. So American Hospital Association accredits hospitals to function, so they are going to be evaluating how they're doing. Well, the other ones are self-explanatory. The American Medical Association is the organization that give you your license. You have, that creates all these requirements for you to become a doctor and to practice in this particular field or specialty. Nurses, the same. There is an, American Nurses Association. And medical assistants have the AAMA, the American Medical Assistant Association. So every single profession have an association that you belong to, that you can be member of, is the one that, regulates, supervise your certification or your licenses or your licensures for that matter. So that's basically what it is. So we get a little familiar with who works where in certain facilities where all these people is going to be working. Because remember, we are preparing you to make sure that you understand when we get into the medical record, all, that's the information that we need. Any questions about the healthcare delivery system? Remember? And this was, accreditation regulations in HIPAA is the next one. So we're going to see now a little more about this health information technology and management. So HIT, that's how we, that's the acronym that we know, this way of, managing all these electronic medical records. We're going to see who accredits organizations like hospitals, what regulations you have to follow, and what is the function of HIPAA? What does HIPAA do now that we are working with more advanced technology, which is electronic medical records? So I'm going to talk about this and learn some of the stuff that are very important for you to understand, because somehow you're going to get involved with medical records and you need to know all the rules and regulations, all the policies of how to handle information that you receive from the patient, but it's not documented in paper. Now it's going to be documented in electronically. Now you're going to need a login ID and password, and how you have to, how is it that you have to be managing this information now that there is in the system. So we're going to be thinking about how we did with the paper-based medical records, all the regulations that we follow with them, they do not change. Legally speaking, all the regulations or, HIPAA regulations, for instance, accuracy, when we enter complete the information, the medical records, none of those are going to change. So what's going to change is how the system works, how information can be entered into the electronic versus paper. You're going to be more like involved with this. So the patient is going to be involved with the medical records as well. So patient is going to have access to the patient portal. So the personal medical records or patient's medical records. So things are going to start changing because, technology, you have more features, so to speak, that you can deal with, that can allow this interoperability versus just having a paper-based medical record that can, be misplaced, lost. That's not going to happen with the electronic medical record. So how are you going to find, how are you going to retrieve a medical record? Just not going into any of these physical open shelves or cabinets. You're not going to follow all these color or, numeric or alphanumeric codes. No, we're going to have some system that is going to be a lot easier, and it is at your fingertips. It is so simple, like just type in the first letter of the patient's last name. Then selecting the section of the medical records when you're going to enter is going to be pretty simple. You just need to get familiar with the type of software application that your organization is using. And how you're going to do that? You're going to ask someone to train you. You're going to ask someone to show how it works. So that's basically what it is. So we're going to talk about these, regulations, policies first, before we actually enter what it is, medical records, electronic medical records, and electronic health records. So that's basically what it is. So every single organization needs to be accredited. And for that reason, we have certain regulations to accredit any organization. Just think about restaurants, buildings. This is a type of accreditation that you're gonna get. So you can open business. That's basically what it is. But you have to follow certain regulations. Now, the building itself, the facility itself, needs to be accredited. They're going to check location. They're going to check the number of rooms. Remember how many people you're planning to enroll in your facility. How many people is working here? What specialties are you going to have? What is the equipment that you're going to have? Safety measurements, fire measurements, just in case something happened. The license of each one of these people that's going to be working. So not only the facility is going to be accredited and evaluated, but the practitioners who are going to be, interacting to offer, healthcare to the patients, they have to be licensed, they have to be certified. Every single time that you see a advertisement offering a job, probably you have seen them. They want you to be certified on that particular field or licensed. If you do not have this, the chances of getting a job are very slim, because this country is the country of licenses. And certificates. You need certificate, you need license. You have to be credentialed in anything you do so you can prove that you actually have that training. So that's basically what it is. All these accreditations, some of them are voluntary. Voluntary means that if you want to open your business, you have to go through all these regulations. If you don't, then no worries. If you want to become a nurse, you have to take, your national boards, your licensing boards, or your national certificate as a medical assistant. Some of these regulations are, required by the organization for them to hire you, but it's voluntary from your point of view. You want to do it or you don't want to do it. You want to go to the program, you decide. You want to take the boards, you don't want to take, you cannot practice. Because we have, again, all these specialties that, requires certain training. And you have to, renew these certificates and licenses all the time. So we have this organization that regulates what certificates, what licenses do you need, and what is the type of core program that offers those. That's why we have a human resources in every single, in these industries when you look for a job, because they're going to check your credentials, all your information, all your training, all your certificates or licensure. That's basically, and those are approved by government. So that's basically what you can't just show up over there and say, oh yeah, I have a license, but I bring it tomorrow. It doesn't work that way. You have to show it, and you have to prove that that you learned this. And how you're gonna prove? With this license or certificate. So that's basically what it is. So we have these government regulations because, if the government doesn't intervene with this, probably things are not gonna be done. So every single time, once again, that you're gonna present, you're gonna apply for a job, they're gonna ask you for your credentials. What is it that you learn? What is it that you specialize yourself? So that's basically what it is. For medical doctors, it's very important because we not only diagnose the patient, but we also claim, reimbursement for those services provided. So we are required to have more than one license. It's not just the license as a doctor. You need license to prescribe controlled substances, the DEA number. You need a national identifier as a medical provider, because that's how insurances are going to recognize us. All these new credentials are like your social security number, your license, your driver license number. See, you're walking around, they don't ask you for your social security. Okay, can I have your social security, please? No, they said, may I have an ID, driver license? Because it's the most common ID, right? But we have passport. We have a social security number. But people do not ask about, okay, show me your passport. No, usually, but we do have other credentials that identify us. Medical providers, medical facilities, hospitals are identified by a ID. Every hospital has one ID that identifies them, like a social security for that particular organization. Everything has an ID. So that's basically what's telling you. How is the insurance company going to pay us? It's not through our license as a medical doctors, No, this is as a, national provider identification, NPI. And the organization has a unique identifier as that particular hospital. See, Bellevue Hospital has a number. And if we enter the number in the system, immediately says Bellevue Hospital or any of the other hospitals for that matter. So that's how we identify, that's how we get paid. This is the company identification number. So the companies, the organizations, the facility, medical facilities, all of them, doctors' offices, they have a number. Yes, they have a name too, but it doesn't matter. This is like the patient and the medical record number. I don't want to see my name on the medical record when you enter my information. I want to see numbers because numbers, protects your, that's part of the privacy. So that's what we have, numbers. Your driver license is a number. Your social security is a number. Your passport, we have a number. Well, our license as a medical doctors is a number. The DEA, the Drug Enforcement Administration, is a number. That's basically what it's trying to tell you right here. So the government has all these regulations for us to, be able to get these certificates or license. Now, state laws. Remember, we have local laws, state laws, federal laws. What is the highest? Federal. But the federal cannot, undermine the state law. If you have a federal law, means that you are covered in all the states in this country. And you have to be abide by that state law. For instance, it is not state crime to kill someone. It is a federal felony. It's a crime. So every state is gonna see a crime as such. States have their own regulations as well. So we have local, which is the facility itself has their own regulations, their own laws. The state, as a state, they have laws. That's what we have, licensures, which are given by the state. Licensures are not given a federal level. It is state-wide. And whatever this state decides is how it's going to be done, regardless of what the federal law says, because these are different regulations. Let me give you an example. Well, I gave you one already, license. You want a license as a medical doctor, you studied here in New York, you took the medical boards right here, you're licensed in New York. Can you go work? You can go work anywhere else, but now you have to meet the requirements of that particular state because the state changes its regulations. Abortion, remember, that's a hot topic right now. Abortion is legal in some states, but it's not legal in others. It is illegal. Gay marriage, it is legal in some states, but it's not legal in other states. I'm mentioning all this so you can understand how these certificates and licensure apply just the same, because each state have their own regulations. And we cannot go beyond or below or under those regulations because we are going to be, violating these codes of the training that we have. So all these states, they just provide all these regulations, not only in regards to the operations of the facility, but also how our credentials are going to work, how they function. And if we do not have those credentials from the state, we cannot practice, or they're gonna limit the facility to have certain services being provided. I already gave you an example because I gave you examples that are easy to understand. See, our school do not have a nursing program. But let's say that we decide that we are going to open the nursing program. Just by ourselves. We decide, the owner of the school says, you know what, Professor, we're going to start teaching nursing from now on. Well, it's not the decision of the owner of the school. He has to apply to the Department of Education, present the curriculum of the new program, wait to be approved and to meet all the requirements. So they're going to come to the school, they're going to evaluate the school. Okay, where are you going to have the nursing program? What is the classroom? What is the laboratory that you're going to have here? What is the equipment that you're going to, oh, who's going to be teaching that? Where are the nurses here? That's how it works. And if you do not meet all those requirements, you're just not going to be approved. You cannot open the medical or the nursing program, not legally. If you do it illegally, yeah, you can open your classes, start teaching nursing. Here is the problem when you're going to take the board. Because you don't exist, because the school does not exist, because the school receives a code and accreditation for each one of the programs that the school teaches. The same goes with the hospital. The same goes with the doctor's office. If you do not meet the requirements, you don't have the facility, all the space, the equipment, the professionals to do the job for what you are applying, you are requesting, you want to be accredited for, then there is nothing there. So that's basically what it is. So you have to meet all the requirements, otherwise you're not going to be able legally to open your business. Now, state laws also needs or requires that every single professional, particularly medical doctors, to report all these communicable diseases. Remember, anything that can be passed from one person to another, like COVID, again, needs to be reported. We talk about what is reportable. Remember, child abuse, elderly abuse, spouse abuse, any injuries, any trauma, particularly those injuries caused by gunshots or stab wounds. Why? Because probably this was a violent situation. Somebody got shot, somebody tried to rob them. That is a crime involved. Or it was a suicide. We need to report all of that. Again, we are abide by all these state, federal, and local laws. So local laws, most of the time we call it bylaws. So those are the laws of your organization. So let's say state laws, we're just going to put by, just by, BY. Bylaws, that's called local laws. So the laws of your organization. And we have to follow those. So I apply for a job, I follow the state laws because I'm here in this state. So I do a lot of stuff. But if I move to this particular facility, they're going to tell me what they expect me to do. within my scope of duty. Oh, I do this. Says, no, here you cannot do it. But my license says that I can do it. That's what I was trained. Here you cannot do it, Mr. Oh yeah, you want the job or not? So actually, I'm not gonna get the job because I already became problem. So you're gonna get me in trouble because if I'm telling you should not supposed to be doing that, what are you arguing? Because the state laws, the law, the bylaws, you have to follow these regulations. Your state law can say many things. Yeah, you have a license, you are authorized to do this and that, but the place of work, the person who's gonna pay you, the person that hires you, they're gonna tell you what you, with your scope of duty, what is it that I want you to do here. If I don't want you to do this or that, it's not gonna be part of your job description, and you're not gonna be doing it, even though if you are qualified to do so, you are licensed to do so. For medical assistants, let me give you an example. You're a medical assistant. You work with this particular doctor, whether a hospital, whether a doctor's office, and they hire you as a medical assistant. Then he says, okay, so what are my duties are going to be? What is that exactly, the task that I'm going to be performing? They're going to tell you, okay, so you're going to be standing in the front, you see right there by the counter, the front desk, and you're going to be taking care of the patients. If I need you to translate something else, you're going to be, I call you, I'll let you know. Oh, are you bilingual, by the way? Yeah, my resume, yeah, that's how it is. So that is during your interview. That's why you have to ask questions before you take a job. This is not about, oh my God, I'm desperate. I need a job. And then you're going to end up in a job that you're probably not going to last long. And the worst part is that you get fired, not that you decide to leave. So they're going to say no. And then you're going to say, oh, no, that's not what I want. I don't want to be in the front. I don't want to be dealing with these patients, scheduling appointments, insurance verification, answering the phones. No. I don't like that. I want to be drawing blood. I'm going to be doing EKGs. I'm going to be assisting the doctor on the back. Nothing with that. But that's what the job requires you to do. That's by laws. So those are the protocols, the regulations, or your local, your institution. So those are the things that you're going to be doing. I hope that this is understood. Because, listen, I have encountered this situation many, many times. It's not that I tell a medical assistant or nurse not to do this or that. No, those are the regulations from that particular hospital. And if you do it, and usually you do it and you get caught or something goes wrong, that's when the problem is going to rise. It's not that because you did it, oh, well, everything went right, nobody complains, fine. Probably nobody's going to notice. But if everything or anything goes wrong, you're going to be liable for that. You're going to be responsible, and you cannot come out with the excuse, oh, but my certificate, my license authorized me to do that. Does your bylaws, protocols, laws, regulations states that too? Oh, now we have a problem. See, it's very important for us always during an interview, ask questions. Don't be embarrassed. Don't be shy. Oh, no. If I ask, no, I got this job. Oh, it doesn't matter, but they just need money. Remember, sometimes it's not about the money. And I can tell you that. It's not about money. It's about where I feel comfortable, where I can do the things, where I can breathe. I cannot have someone on top of my shoulders all the time. Working with toxic people is the worst thing that can happen to you. I'm telling you, I lived that, been through that. I know how it is. It doesn't matter how much they pay me. I just quit for my own health. I mean, if I don't do it for myself, who's going to do it? So again, these are the important things about, because that's when you're going to get in trouble. when you do not follow these particular laws, regulations. So that's how it works. Everything that happens within our patients, we have to report it. Because we need, well, I'm talking about every single condition, of course. Because we need to have those statistics. Remember that I told you that every single condition, we need to report it. Some of them faster than others. Depends on the level of risk that we have with this condition that might be affecting the population that surrounds our facility. Remember that we report all these conditions, every single condition, everything, to the CDC, the Centers for Control Disease and Prevention. So that's basically what it is, because that's how they're going to have all the information about what is actually going on with our patients. And we are going to have a precedent. See, we discover or we diagnose, just put it away. Let's diagnose a patient with this particular condition. And then another patient will diagnose with the same condition, and another one in different places. So we're going to see the prevalence of these conditions. What are the conditions that are kind of surging in our area, that are more common? Like, there is a trend now that we have all these conditions coming up. Something is going on. We got to stop this. How are we going to prevent it? We're going to report it so the pharmaceutical companies can, manufacture medications, equipment, or whatever the company fabricates all those equipment to treat this new condition or this condition that is going out of control. We need to start thinking how we're going to prevent it, how we're going to treat it, how we're going to stop. So that's basically what it is. That's the reason why we we are reporting all these medical conditions. Once again, we are not reporting the patient protected information. No, we're not revealing anything about the patient's demographics. We're just mentioning what conditions, what we did to treat it, whether what we treated with work or not, so it can be used as a precedent for other medical providers. How do I know that this particular medication works for this particular condition? Because someone else already tried it and it worked. And if it didn't work, they're going to tell me what are the odds or the advantage or disadvantage of this medication. If this medication caused the patient this type of side effects, that's what we have, these side effects, these contraindications, these allergies to medication, because they were reported prior to the CDC, and we have statistics about that. We have precedent, not precedent, is a precedent, which something that have happened in the past. Now we can use it to learn, says, oh, that happened before. So we got to prepare ourselves to prevent that from happening again. So that's basically what it is. Oh, it's raining. I'm not moving to Florida because see, all these hurricanes, all these tornadoes, tsunamis probably. I'm not gonna move to a part where, you are high risk for this, environmental phenomenon. No, there is a precedent. So if I know that that happens over there, what I'm gonna put myself at risk. So now I know, so I'm not buying there, I'm gonna buy somewhere else, if that was my intention. That is a precedent that someone else have this condition, somebody treated, is very common in this particular area, in this particular state, for this particular population, race, gender, age. That's how we actually figure it out how to deal with these conditions, because if we don't have the statistics, we don't have these people who's going to report all these findings, all these conditions, all these infectious diseases, then it will be a disaster. Can you imagine? It would be like just throwing a bunch of papers right there from different dates, and we have tons of those trying to look for some of these particular documents. Again, it will be very, very difficult. So that's why we have laws and states, so we can put everything organized. And laws and regulations is because they're going to protect us if we do the right thing. And it's going to punish us if you don't do the right thing. So it goes both ways. So it's important for us just to learn the laws and understand what is it that we can do or we cannot do with our credentials. That is how it works. Let's talk about the Joint Commission. Pay attention to this. This is going to be a question for your exam. So what will be the question for your exam? Who accredits medical facilities, particularly hospitals? Because they're going to ask you about that. That is the JCO, the Joint Commission. When I started working back in 2005, something like that, that was long ago, right? It was called JCAHO. We call it the JCO. Now it's simple. Now it is called the Joint Commission. That's it, the Joint Commission. So you're probably not going to find the JCAOH. You're just going to say you're going to look for the Joint Commission when they ask you who accredited hospitals. Now, they accredited nursing homes, home care agencies, and behavioral health care institutions. They do not accredit doctor's offices, medical clinics, no. This is for large organizations, and these large organizations are the organizations that are funded by the government. If you are accepting Medicaid, Medicare, oh, you're going to have the Joint Commission coming after you. So hospitals, remember, they take every single insurance. Medicare. So what is Medicare? Well, Medicare is an insurance that is given to the senior citizens, someone who is 65 and above. That is Medicare. Medicaid, on the other hand, is an insurance that is given to people that have low income or no income. So that's basically what it is. When I went to school, there was Medicare, Medicaid. That's it. Plain Medicaid. There was no there wasn't all these other insurances under Medicaid. There was no such a thing as a Health Plus, Metro Plus, Fidelis, and all these other insurances. They weren't at that time. They are recent. They are not too old. They are like 20, 25 years old, something like that. So if you're not 25, probably you never heard about this. But back in the days, it was just Medicaid. Medicare has always been the same. We will discuss that just for you to understand, because the Joint Commission deals with all these huge organizations that take all these insurance, particularly this government insurance, because this is paid by the taxpayers. So this organization has to oversee what's going on with the money from the taxpayers. Well, government, so to speak. So basically, that's what it is. Now, the Joint Commission usually, remember, the question for the exam is who accredited hospitals? The Joint Commission. What does the Joint Commission do? Accredited hospitals. They are the ones who actually tell the hospital, yes, you can open your doors. No, we're going to close your business. That's basically what it is. So let's say that you're going to open a hospital. Let's just assume they can't just say, oh, I have a lot of money, I'm going to open because I have everything. I have the people, I have the equipment, I have a beautiful building. I'm going to have a state-of-the-art equipment. Yeah, that's nice. That's what you need. You need to apply. Then you submit all the requirements, you contact the Joint Commission, and the Joint Commission is going to tell you, okay, so you need, that's like over 500 pages. So no, read all these and meet all these requirements. Of course, you have to have attorneys, you have to have architects, you have to have a lot of people who's going to read and interpret that. Then, okay, you're going to submit that and it says, yeah, I meet all the requirements. Someone is going to come to your place and it's going to look at all your facility physically. It's not what you're telling me. I have to evaluate whether what you're telling me, what is here on paper, is actually real. They're going to come to facility. They're going to check all the rooms, the equipment, all the credentials for the people that's going to be working there, the money that you have, and all the requirements. And they said, okay, you can open your business now. You are accredited. So now you're going to receive a accreditation. But if they say no, goodbye. That's it. You cannot open your business. This is like if you're going to open a restaurant, you're going to open a barber shop, a beauty salon. You have to get permission from the state, from the local area, the authorities. That's accreditation, whether you are allowed to open your business over there. And they're going to come and check the place and see whether whatever you say that you're going to open and your services you're going to offer, you're going to meet the requirements for that. That's how it works. This Joint Commission is going to come every 3 to 5 years unannounced. They're just going to show up right there in your office, a group of people, doctors, nurses, people who really knows how medical works. This is not an undercover someone else. Oh, go check there, take pictures. No, that's not how it works. This is people who really are professional on the field, and they're gonna come over. They're not gonna tell you, hey, we're coming to visit your place. Because when they tell you that they're coming to visit your place, guess what? You're gonna fix that, right? So they're not gonna tell you, and they're just gonna show up unannounced. Everybody can be stopped at any moment and ask things about something. What is the fire extinguisher? They can ask you. Oh, what is the emergency exit right here? Why is it that the doors in the bathroom do not have these logos for males, females? Why don't we have a ramp? Why don't we have, bathrooms that are for, wheelchair? Oh, this room is too small. Well, think about it. So they're going to come over and they're going to examine the medical records. They're going to pull medical records. They're going to ask, of course, when they are there, they're going to identify themselves. And randomly, they're going to pick up medical records from here, from there. Someone who really knows is a doctor who knows about medical records is going to go there, review it, and they start recording that information, and then they give you the hits, whether you pass, whether your accreditation is suspended, whether you are in probation, whether we're going to give you this particular time to fix the problems, then we're going to come back otherwise, or other says, you know what, You have too many problems right here. Even though if I give you time to fix it, you're not gonna fix it. Your business are closed. That's basically what it is. So this is very serious. So think about the accreditation, joint commission, period. That's it. Any questions about the joint commission? It's very important. HIPAA, how there is no way you're not gonna have questions about HIPAA. Well, the first one is right here. Protected protected health information. You need to know this. They're gonna ask you, what is PHI? Simple. See, this is an acronym. What does PHI stands for? PHI, Protected Health Information. So they're gonna give you certain examples and they're gonna ask you which of these items is considered, or which one of these terms is considered protected health information. Since I have been talking to you about this protected health information from day one in this course, and always been talking about how important it is to keep the patient personal information protected without, disclosing it, then you should know by now. Anything that has to do with the patient's name, last name, anything that identifies the patient. If I have your phone number, can I identify you? Yes. If I have your address, can I identify you? Yes. If I have your email address, of course. If I have your insurance ID, can I identify you? Of course. Any information that identifies the patient is considered protected. Remember, I can reveal all the information about conditions without mentioning your name. Am I violating HIPAA? No. If I mention one of you in the class and I tell in public, hey, you, Albert, you failed this particular test. That is violation not HIPAA, but the student's privacy. You know that that's illegal. If I said something to you in front of the other students that embarrasses you, that put you on the spot, that's a violation of the student's protected information. Well, what makes you think that with our patients is not the same? That's why we have to keep the patient's personal information confidential. Anything that identifies the patient is going to cause trouble. We have to keep it protected. If I don't mention your name and I just say, hey, diabetes is very common condition. Am I saying any names? No. The ranges of someone to consider that had diabetes is from this level or from this range to this range. What's the range? From this value to this value. Am I saying anything? Am I mentioning names? No. It's like if I said, oh, I work in this school. Did I mention the name of the school? Not at all. Did I mention the hospital? Well, sometimes I do because I did really well, so nothing to hide. And I don't say bad things about my hospital or, well, the places that I work. Because I'm very grateful that they gave me the opportunity, that I have the chance, that I made some money over there. But I did good service, provide good service in return. So again, this is protected health information. So we should not disregard any information. That's why when the patient is telling us, the patient is there, patient is talking, So you cannot say, oh, the patient says, oh, I have some, I think that I have some venereal disease. Well, the patient is there, people seeing the patient, talking to you. You should not repeat anything loud in front of other people. Tell you what happened once when I was working at the emergency. I have one of these doctors, even though if I mention the name, you will never know who that is, but I never mention names. We have a patient, right? And then the patient was diagnosed with gonorrhea. Well, this medical thought, I believe that's my impression, but he was a little dumb because, already, can you imagine as a medical doctor, now knowing that you cannot disclose particularly these sensitive things? See, when I was checking a patient at that time, and there were like a lot of people right there. And he went and says, hey, you, what you were doing, Jiggy Jiggy? You have gonorrhea. He was laughing. The patient became pale. I don't know, maybe I would jump on top of you and beat you up. And definitely I'm going to be free. I'm going to be rewarded for that. How can you be so stupid to say something like that? Well, a few weeks later, the doctor was no longer working there because there was a lawsuit for that. Because first of all, it was a violation of the patient's privacy because you're revealing a diagnosis in front of everybody, and the way that you did it, it was on purpose. So not good. Even though if it is not on purpose, but if we do not follow these privacy rules, we're going to be in trouble. So just because the patient is telling you something and is telling you something in very low tone of voice, don't tell them, speak louder. I don't hear you. What's wrong with you? It might be something sensitive. So when you see a patient trying to kind of whisper something to you, instead of, retaliating against the patient's behavior or attitude, you should understand and bring the patient to another room. Or if the patient is telling you, oh no, I'm going to talk to the doctor when I get there, okay? So if I ask you what is the reason of the condition and they don't want to tell you, no worries. Continue as nothing happened. Oh, no problem, Mr. Brown, Mrs. Brown. That is fine. Continue whatever you were asking. And if patient said, no, I'm not. Remember, the patient had the right to refuse. And sometimes when there are sensitive information and I have all these people surrounding me, I don't want anybody to know what I'm here for. What should I? That's my privacy, isn't it? So again, very important that we understand all this. For that reason, we use now medical record numbers because we don't want someone to see, oh, this is the name of the patient. Because when they see a medical record number and see some information there, yeah, have diabetes, have this, have that, but it's just seeing a number. How do I relate that? Because we do not know. The medical professionals know, because when I enter this number, the name of all the information of the patient is going to pop up. But when the patient see just the screen, which shouldn't have the opportunity to do that, because you're supposed to have the screens, facing you, not facing the patients, or leaving them open when you're not using it. So that's basically what it is. So we are going to make sure that we keep our patients' privacy protected. And that's called the HIPAA privacy rule. So when we talk about HIPAA privacy rule, it's not just privacy. We have privacy, we have confidentiality, and then we have the HIPAA security rule. So we have all these securities, but all are then HIPAA. So you're going to be asked like at least 5 to 10 questions about HIPAA. You're working with the patient and one of your coworkers asks you to get access to their computer and they have forgotten the password. What violation are you be accused for if you give your code or your passcode to the HIPAA? The patient's family ask you for the condition of the patient. What regulation, what rule are you violating? HIPAA. Remember, you're not supposed to be revealing anything about the patient. It doesn't matter who is it. Is the husband, the wife, the boyfriend, the daughter, the son, the grandparents? No one should know. No one. The only one who you need to tell the things are the patient. If the family member, if someone else asks you, and the answer is there, it says, ask the patient. Ask the person to ask the patient. Usually, it's not the answer that you're going to get there, but that's what you could do. Oh, I'm sorry, but I'm not authorized to tell you that information. Do not tell, oh, talk to the doctor, because the doctor is not going to be able to tell that because you are not the patient. So we do not tell other people. No one should be telling anything about a patient if it's not the patient. Now we ask them, the doctor is going to tell, I'm sorry, I cannot give you that information. This is confidential. That's the same thing that you're going to respond. So anytime that you see questions like this, you're going to go by protecting yourself, privacy, 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 and not authorized to do that. Don't be tempted to pick, oh, you want to talk to the doctor? Oh, go to the doctor. The doctor can tell you. Well, then you didn't learn anything about HIPAA because the doctor can tell the patient, the family, or the friend of the patient anything at all. So if you cannot tell, the doctor cannot tell. The doctor only can talk to the patient about the condition, not to anyone else, except if you're a minor. And except if you are a minor and it's not related to anything sensitive, like sex related, sexual orientation, drugs, sexually transmitted diseases, alcohol abuse, drug abuse. You as family, we're not going to tell you anything about that. And that's protected by law because it's HIPAA what regulates that. So there are many exceptions and you need to know which ones are. In general, the general rule for you, you do not reveal any information to anyone. And that's exactly what you're going to do with your exam. No, it's no. You do not have permission. Always look for the answer. No, you tell them, oh, no, I'm sorry, but I cannot give you that information. No. If there is no other choice, that would be, but always you're going to say that you're not allowed to provide that information based on some, legal regulation. You don't have to go that far. Sorry, unfortunately, I cannot disclose that information to you. That's it. The conversation is over. There is no more, comments about it. Go ask this person, go talk to, no. No, because the other person is not going to be able to, and you're going to put the other person on the spot. So again, learn from me. Well, I think that we are done for tonight. We're going to leave this for tomorrow. We're going to continue with HIPAA. It's a lot of stuff about HIPAA because it's the most important thing when it comes to medical information, patients, or personal protected information. So that's basically what it is. Very important. We're going to continue with this tomorrow. Oh, thank you very much for attending the class. Have a good night. Get some rest. Tomorrow's another day. So see you tomorrow.
Good night. See you tomorrow.
Good night. Remember, if you have a question, just don't hesitate. Ask me. I have no problem with that. Okay. Good night. Good night,
Good
everyone.
night.
Good night.
Good night. Good night.
Good night, Professor.
Good night, Jasmine.